What happens in cancer that these cells become so intelligent that they know how to hide from the immune system.
I feel when patients are in a state of acceptance, I feel every cell of their body is somehow in the state of acceptance as well. But when there's that rejection in their head, I feel they're in a constant state of resistance.
Mahatma, 1 in 2 people are going to be diagnosed with cancer in their lifetime. Can you imagine 1 in 2 is like half the population.
You can't sleep when you're stressed out, and the human mind doesn't make the best decisions when you're sleep deprived.
My message to simplify things has always been freshly cooked, homemade, healthy food.
Welcome to the Luke Coutinho Show, where we can learn to reimagine our lifestyle.
Dr. Sachin, what a pleasure to have you. My patients know of you as a very compassionate doctor every time we talk about that, because I think that's what patients look for today when they're diagnosed with a cancer or any deadly disease. While there's great medication, great expertise, I think every human craves for compassion. And that's one commonality that our patients speak. So thank you so much for that. And it's a pleasure to have you on our show today, Doctor. Doctor, this show is just reimagine your lifestyle in a world with this content overload, people making based on Instagram content, and people stopping treatments in between out of fear or because another profession of medicine tells them that this isn't good. All of this is creating problems. At the same time, we live in a country where cancer is becoming more and more. The numbers are dramatically increasing. The name of our show is Reimagine Your Lifestyle, where we just want to leave our audience with the most simplest ways where they can add structure to their treatments, prevention, if they're already sick, all your expertise that will help in their overall recovery. So thank you for taking time out of your busy schedule to be here today. Doctor, I would love for you to start with your introduction. Why oncology? Take us through your life of choosing medicine as a field and why you finally arrived at oncology, including your brilliant stint in the UK. I would love for you to take us through that.
So thank you, Luke, for having me here. I'm really an admirer of your work, and many of my patients do the report about the good benefit that they've had with you. I'll tell you, when I was growing up, I was really interested in the scientific world, and comments about my compassion. I think that is when I reflect on it, maybe a combination of two, compassion and science. It steers one to a career of medicine. Okay? In addition to that, I think for us who grew up in India, your influence from your parents is a big thing. So my father had a great influence in what is the right thing to do, how I can help people, and at the same time build a career. So that steered me to medicine. And then in second year of medicine, what I realized was we were reading so much about oncology and cancer. So in second year book of pathology during our times, more than 60% of the things that we were made to learn or know about were related to oncology or cancer in some form or shape. But the moment you move to third year and talk about management and treatment, there was hardly anything. And whatever you had was relatively crude in what I feel at that time compared to now. Now, unfortunately, I had some very close family member during that period in my medical school who underwent this experience of being diagnosed with malignancy. Actually, really gave me an insight of what is the need of the hour. And at that age, you are also full of bravado. You want to fight a big battle. So I thought that this is the biggest battle to fight, which is actually to take on the biggest adversary, which was cancer. So somehow I got steered into that direction, and then one thing led to another. After my medicine, which I did from Nagpur University, I was looking for opportunity to get postgraduate training and have honed the skill that which would be top notch, best in the world. So that took me out of India because during those times we were still slightly lagging behind in terms of training opportunities and the kind of training we were getting in oncology. There were very limited opportunities. So that took me to USA, mainland Europe, and then finally to the UK, where I worked in premier institutes such as Royal Marsden Hospital. And I've worked with extremely big names there. Professor David Cunningham, Ian Smith, Professor Stephen Johnston, Nick, these are people who have invented drugs that are being used today, who have invented protocols that are being used today. So that's where my thing of, understanding the research aspect and the aspect of how to actually think of the disease at the molecular level. But at the same time, not forgetting about the compassion and not forgetting that you're ultimately looking after the patient. Then I moved to Birmingham, Queen Elizabeth Hospital, and I got the opportunity to serve as head of oncology services at Nottingham University Hospital. Nottingham is one of the premier institutes when it comes to management of women's cancer, especially breast cancer. Some of the protocols that are developed in Nottingham are being used world over. So I was possibly the first Indian passport holder to have that opportunity. So, and I'm sorry, I can keep talking about myself, and you actually, when you ask this question, it's a long journey, but ultimately, after many years, I felt that I had to come back to help my patients, help our people here. That's how I made it come back. Only about a year and a half ago, I've come back to Bombay.
Thank you for sharing that. I want to pick up on a word that you spoke, looking at cancer at a molecular level, which is absolutely fantastic because I think within the field of medicine and outside of the field of medicine, we also have to start looking at that amount of, level of detail at a molecular level, not just copy paste nutrition, where you Google 10 foods good for cancer and you eat it thinking it's going to, put your cancer into remission, but rather moving into nutrition at a molecular level, looking at anti-angiogenic foods, foods that have the ability to regenerate stem cells, help the immune system. So I love that you picked on that word. So with your experience in the UK and everywhere else that you practice, doctor, when you come back to India, now you practice in Mumbai, what are some of the things that you have been using, based on your experience, your knowledge, and of course, experience and wisdom in your current practice in India today?
So when I came here, I was in a bit of a, and I must say I grew up in India, but I stayed most of my professional life outside. So even though I knew that my working here might be different, I did not imagine it would be so different. So my main concern in the first 3 months was that there is a huge disparity in the quality of care that is being provided across board. Okay, and it does not mean just geography. Even in one part of Bombay, kind of care, kind of care that you get is very different to another part of Bombay, and nationally it is completely different. Hmm? That was one disparity that I saw, and it is world over, but it is not that in your face that I saw here. The other thing was that the amount of time and compassion and the detail that is needed to be given and the thought that is needed to plan the treatment for patient was not there. So what happens is in India when you get when there are doctors who are extremely experienced, have been in the field in the geographically here for a very long time, so they may not have enough time in their hand to go into the details. But what my concept of working is try to personalize, look at the precise option and have a target in mind. That's the PPT model, precise, personalized, and targeted. So looking at everything at a granular level, understanding what is the makeup of cancer, what is the genomic makeup cancer, what is the molecular structure which can be used, which is what precision oncology used to be. Then at the same time, looking at the patient characteristics of, what is it that can be modified to help the patient assist him. Because a lot of patients, you'll be surprised, would just think, oh, I just want surgery. I'm scared of chemotherapy. I don't want chemotherapy. And some people say, I'm scared of surgery. I don't want it. And sitting together as a team of doctors, understanding that and not forgetting the psychological aspect. So combining this was an initial challenge, and trying to have this uniformity is going to be a challenge. But at my level, I've been trying to implement the same standards of care that I would be offering to a patient somewhere at Harley Street in London or even in New York. But at the same time, we want to integrate our own local, knowledge. So, meditation, yoga, mindfulness, and helping patients cope with the disease that is a big aspect of providing a comprehensive cancer care. So I've been trying to do this at my level, and I think I've got feedback from several patients that they're really happy. I'll just give you an example of one of the patients I just saw day before yesterday. So this lady um, has a high risk, had a high risk breast cancer, had surgery, but it's a triple negative cancer, and she needed the chemotherapy. Okay, now she is that type of personality who gets very anxious very easily. The first few cycles she was fine, and then suddenly she started getting side effects. Doctor, I cannot do it. I just cannot do it. And then I actually sat her down and we looked at a dose. I told her that, see, you might be sensitive to this dose of treatment. What we need is to try to bring down the dose and see how you can cope. She said, Doctor, I just don't want it. So I referred her to the psycho-oncologist. We gave her some time to think, and I said, see, if someone is putting a gun on your head or, poking a knife in your head and saying, do you want to have treatment or not, or do you want to live or not? At that point, when you're in pain and difficulty, that is not the right time to make a decision, right? So I said, let us get you out of this potential tiredness and fatigue that you're experiencing because of treatment. We gave you some medicines, take some break, then come back. Now, when she comes back after all of this, I spent almost an hour with her. Okay, she come back regenerated. Doctor, you're right. I have walked this so far. Okay, I have fought the cancer. I know the surgery was difficult, the chemotherapy was difficult. I want to complete the journey because I want to get the most benefit out of it. So having that time and the ability to make the patient realize that this is the right thing for you, along with getting help from the whole team, it makes a huge difference. So she's now started her treatment again, and I'm hoping that she remains well because we are waiting for some genomic results for her, and then based on that we will tailor her treatment. Hopefully, should never come back.
Doctor, it's amazing how you share this story because I want to build up on this like you. And that's a question I want to also bring up because it's a huge concern for me where people stop their treatments. One is because of fear, but you had the opportunity and your team to work with her. We've also noticed that sometimes patients come to us in between and they're like, we can't do the treatment anymore. And what we've realized is because we're constantly assessing them on their sleep, their nutrition, their emotional wellness. They've been sleep deprived in the night for whatever reasons. You can't sleep when you're stressed out. And the human mind doesn't make the best decisions when you're sleep deprived. So just giving them 1 or 2 days to think, they come back with their own decision made that, oh yeah, I think I should go through it. But I'm grateful that you are able to do that. How do we build a system of uniformity where this is not about one doctor against another. This is not about one field of medicine against another. There should be a uniformity like amongst doctors. Some doctors do it, some don't. And I'm not going to say medical world. Some nutritionists tell clients, stop a treatment. Some say, no, you have to continue the treatment. What do you think it takes to build uniformity of compassion, time, putting the patient first, beyond the symptoms sometimes? That's exactly, and your patients have always said this, and I like what they say, that Dr. Sachin puts us beyond the symptom, which means you've established a symptom. But what are the other things that we can do? It's not just chemo, it's not just radiation, it's not, they speak about meditation, yoga. Now I know where it's coming from, your suggestions, but what does it take for us to create a system? Does it go back to our days of education? Does it come through new refresher trainings where there's uniformity in all of these things so that patients have the ability to probably get better uniformly as well?
Luke, that is a very deep kind of question, and I say deep because see, it is not dependent on one person. Like you said, some of us are already doing it. And I know a good many colleagues, in Bombay, name a few actually, who are doing it already, okay? But it does not have to be dependent on an individual. We need to create that kind of ecosystem. And what I feel is, see, there are two aspects. So most of us doctors, we become doctors for, we want to help people. We are interested in science. We like helping people. But at the same time, we want to have a stability of career, not just me, it's just other people. It's a very natural human thing. And what I feel is that realization in the healthcare provider community that this is the best way to keep your patients with you. This is the best way to expand your services. So that realization has to come from the health provider side. But the bigger challenge is going to be from the patient side, which is how do you actually explain to the patient that this is the right treatment for you, and also give them that power of analysis, give them the power to understand why we are doing the things we are doing, why we are not doing other things. So some patients will just come and say, "Oh, doctor, my sister had breast cancer and she just had surgery. She never had chemotherapy." People have that thought that one cancer means the way it was treated is same. There are 200, at least 200 different types of cancer, and when you subdivide it based on the genomic makeup, each cancer can be subdivided into several tens, if not hundreds, of different types of cancer. So you can imagine what kind of different types of cancer and different types of disease cancer. It's not just one disease. So, so that ability will come. One is through education. The second is to actually integrate. Okay? So this integrated approach of all healthcare providers, and it is not just doctors. Okay, clinical nurse specialists, nurses, nutritionists, support workers. It has to be a complete ecosystem, and I think our country is just ripe for that kind of build-up. For example, the kind of work you are doing, you are part of that ecosystem. I don't know whether you wanted it to do it voluntarily or it is just there because people watching this podcast, people thinking, you never know. Maybe one line or one word I say or you say just triggers something in someone's brain. They do their own research and they go and ask the people. So the patients will be demanding, So maybe one of my patients watches this and says, "Can you please send me to Luke? I want to actually deal with certain things." So it is going to be an integrated approach, and I think this comprehensive cancer care is going to be about the integration of all these services. But I say this with a disclaimer, which is this is just me thinking out loud based on my experience, and I'm sure there are other people who have got different kind of experience. But we keep learning new thing every day. And there's going to be a lot of things that we learn, and assembling and assimilating that together to help a patient is going to be the key.
Yeah, I absolutely agree with you. It's the comprehensive approach. Coming back to your question, I wanted to be part of the system 13 years ago when I came back from the US with this subject. We basically pioneered integrative and lifestyle medicine as a new concept 13 years ago. And the first year was my worst year. We had everyone stamp on us from the medical community. They were like, what is it? We had to say, we're not alternative medicine. You do your job. We're sending patients to you. But please understand the importance of nutrition. Within a year, we were automatically accepted into the system. And today, we touch wood have doctors working closely with us. We have oncologists reaching out to us directly that, hey, Luke, this patient's kidney, can you figure this out? Can you? And it's become beautiful. So there's a part of my heart that literally wants it to become mainstream for everyone because it's fragmented right now. Everything is fragmented, like you said. There is great pockets of knowledge in our country, but because of the fragmentation, a lot of it is misused. I have nothing against Ayurveda, but I have a huge issue when they ask a patient to stop medical treatment and choose nature. I will use certain Ayurvedic remedies, like if a patient after a cycle of chemo is nauseous, we will give them a jeera ajwain tea to drink because we know there's no effect, there's no contraindication with the treatment. Works beautifully for nausea. We can use simple laxatives to, like your prunes and your raisins. But doctor, we were speaking before the podcast, you were speaking about this homeopathic hospital in the UK. Can you tell me, we have allopathy, we have modern medicine, take me through your whole view on all of these things together, because all of them have pockets of wisdom, but I feel they should not be misused alone. Like people may have different views on what I say. Is allopathy the only way to heal a patient? And my answer is no. Allopathy can save your life. It's great. It can help you with your symptom. But if you're not changing your lifestyle, you're not addressing the root cause of why you're constantly getting sick, why you constantly have inflammation, it's an incomplete system. It's a great system when it's comprehensive. So can you take our audience through modern medicine, allopathy, alternative medicine, homeopathy, and your views on this, please?
Yeah, so one of the most frequently asked kind of question or problem that I face in my clinic is, doctor, I am not going to have this. My Someone has suggested I just have this concoction of some leaves and I will be fine. Okay. Now, like you, I have nothing against any kind of types of medicine. So there is Unani, homeopathy, allopathy. There's a complete ministry of Ayush that is dealing with it. Then there is allopathy. But in my opinion, these are really artificial segregation. Okay. There are only two types of medicine. One is that works and that doesn't work, right? One that works, modern medicine will grab it immediately. Okay. Now, Ayurveda. Why I can claim that I have none of us should or have any problem with Ayurveda, because I am member of Royal College of Physicians London and fellow of Royal College of Edinburgh. During my convocation, when I went to the Royal College of London office, the moment you enter there, you enter into a garden, and you know what that garden has? Only herbal plants. So the premier institute of allopathic medicine is has almost 150 different types of herbal plants, from which has all these plants have served as the source of medicine that are being used today, right from let's say some painkillers, aspirin, belladonna, opium. Not just that, some of the chemotherapy drugs that we use commonly, like paclitaxel, docetaxel, they come from the bark of a tree called yew tree. There is a few drugs called vincristine, windblast flowers, which they call sadapuli flowers. I don't know whether you've seen this periwinkle flower.
Yeah, yeah. I read the paper on that as well.
So,
That's big time.
so if someone had any problem with herbal or anything, they would not adopt. This is already there in. So my worry in India is that we have lost our ability that we used to, analytical ability that we used to have thousands of years ago. So if we go to, I'm a big fan of ancient Indian culture and tradition. If you go to our shastras, there are 6 different type of evidence mentioned in the shastra. Okay, which is one that you see, something that is visible. Okay, and there is one that based on an expert advice, one that is based on a testimony of an experience. So even at that time, nothing was taken for their word. Someone said, okay, this is the best thing. It was not accepted. So you heard of all these big debates that went on. People arguing, even Shankaracharya arguing against Pandit Madan Mohan for some philosophical question. Similarly, even from health point of view, nothing was taken for granted. Everything was tested. Everything, there was a system of collecting evidence. Okay, there was 6. In modern medicine today, there are at least 4 different levels of evidence we follow. Now, my worry is we already had, in some shape or form, already there. Today, European Society of Medical Oncology, American Society of Clinical Oncology have developed their own system of levels of evidence. We had that thousands of years ago. They are not exactly similar, but that was the process. So, modern medicine would adopt, like you said, you are seeing experience. I'm sure you are collecting data. You will be able to publish. This is what I found. See if it works for your patients. Then we deploy the same strategy for our patients. See they don't have any toxicity. We then come to a conclusion that this works. So my thought is that instead of segregating different types of treatment, try to get what is best from each kind of patient. So the detailed history that a homeopathic doctor takes, I don't know whether you've been to. Oh my God, it's amazing. So we teach. I used to be a teacher for the Royal College. So we used to teach students to go into granular details of understanding each and everything, and that is what homeopathy might teach us. So these are kind of different things that needs to be integrated, and at the same time we need to just not follow if someone says, do this or do that, you need to go and think analytically. But many of us may not be able to think analytically because we're not trained for that. In that case, we go to the levels of evidence or we create evidence. And I'll tell you, in HCG, where I work these days, so Dr. Ajay Kumar is the chairman of HCG. He and I, we constantly have this, sessions on thinking on how India should create its own evidence.
I believe that.
Yeah, so HCG has 25 hospitals running all over the country. So we have a geographical spread. We are collecting data, and very soon, and we are also running our own trials. So if you have got some idea, just say let's just for the sake of discussion, we say that you found that maybe half an hour of meditation before having chemotherapy in a patient who gets very sick will prevent it. And you want us to run that trial, we can run it immediately. So this is the kind of ecosystem that we are trying to create. And so we are slowly building that up. And I think there will be a point where, we have met today again here, but there will be a point that in a couple of years we'll say, I have developed this. Now let us try to, integrate all of it.
Doctor, sometimes patients you specialize in women's cancer. There could be an ER positive breast cancer patient, same stage, same cycles of chemo, which are going to be administered, but two completely different outcomes. Usually, why does this happen? It will be the genomic makeup, several factors. With your experience, why does this happen?
It's an interesting question. So, I mentioned to you I was working at the Royal Marsden. So one of the professors, Professor Ian Smith, is actually a pioneer in developing this aromatase inhibitor therapy against ER positive disease. And I had the opportunity to interact with him many times on this. So see, our depth of knowledge and understanding, it is increasing day by day. So the ER receptor what we know of is not just one type of receptor. Then we found out long time ago that there are two big subtypes. One will work better, one will work not that good. Similarly, the percentage of ER receptor positive cells in cancer may differ from one patient to another. The type of drugs we are using may actually not be most beneficial for certain types of ER receptor positive. Again, what we believe that it is going to be two things. One is the biology of the cancer and the metabolism of the patient. And the third thing would be the type of drug we are using. So we know conventionally these conventional cytotoxic chemotherapy drugs were not that effective in ER positive patients. So to just tell you, so there is something called as neoadjuvant chemotherapy, which means if a lady comes to us with a lump of breast cancer in her breast, which is not operable or cannot give you the best cosmetic outcome, you try to shrink it. The way you do it is using chemotherapy. So if 100 women were given chemotherapy and they were all ER positive, only 10 to 15 would have the maximum, shrinkage or complete disappearance of disease. Whereas the other types of cancer, which is triple negative and the other one HER2 positive, they have almost 70 to 80% or 60% will have a good clinical benefit. So ER positive were more resilient, but some of them are more sensitive. So what we think is there is going to be some genomic makeup that will give us the explanation. In fact, I'm working on with one of the Indian companies that has developed this predictive model of whether we can use the genetic makeup and some algorithms to see whether this ER positive patient will be able to actually tell which will respond to chemotherapy and which will not respond to chemotherapy. I'll say this, no two cancer patients are the same. No two cancers are the same. If the same person gets two cancers, they will not be the same. Even if you take the lump of cancer and you analyze the top bit of the lump and the bottom bit of the lump, that might be different. This is a big challenge for oncology community, and it is called tumor heterogeneity. So we now understand that, and the strategies we plan is completely based on the expectation of how that cancer will behave. So there's a field of oncology called predictive oncology, so that is going to use predictive modeling based on the genomic makeup of the cancer, and prediction of how they will respond to therapy. So in times to come, we will have better answers on why this happens. We know some of it, how it happens, and how we can prevent it. Because now we've got wonderful new drugs. Just pop in 2 tablets a day instead of chemotherapy, and ER positive cancer will shrink. So these are under trials, and like I was mentioning to you, we are really at a cusp of revolution because we have now new biological therapies, targeted therapy, precision oncology medicine, and immunotherapy that are going to change the paradigm completely.
That's very promising and reassuring for all of us, doctor. Thank you for explaining that. I still have a worry when I look at oncology outside of the medical perspective, because the medical part is not my expertise. While we look at the human body as a whole and we look at disease as cellular, starting off at a cell, starting off at some imbalance which was created by a gene not behaving itself or by a DNA mutation or whatever it is. When I look at lifestyle around and the impact of ultra processed food on inflammatory markers in the body, when I look at sleep deprivation and the massive amount of medical studies showing the direct impact of sleep deprivation on changes in our molecular behavior, when we look at the amount of stress levels, chronic stress, I'm not saying day-to-day stress, people who are constantly stressed out, high cortisol, high adrenaline, high CRP, HCRP, all of the markers, medically caused or lifestyle caused. My personal take is all of this will be evident now and in the future for everything to work together. When you look at a patient beyond the symptom, what are you seeing that's changing in today's world that is actually also causing, like, there's so much of medication, but the numbers are yet increasing.
Yes.
What comes to your mind as a oncologist and as a human being seeing everything together?
Can I share some stats with you?
Please.
Okay.
Yeah.
So CRUK, Cancer Research UK, is a well-known organization, does a lot of good work, research, population studies and stuff. So CRUK came up with some statistics, and when I last checked on the website, what it says that in UK and possibly in Europe, in next maybe decade or so, 1 in 2 people, mark my word, 1 in 2 people are going to be diagnosed with cancer in their lifetime. Can you imagine? 1 in 2 is like half the population. Some type of cancer, maybe a skin, maybe prostate, whatever. And 1 in 3 people might succumb to the disease. So, see, we are going to become developed country. There is no doubt about it. Okay. But with the pleasures of developed country, we are also going to face the problems of developed country, right? So this rising incidence, I think, is going to be one of them. Okay. And you mentioned your first word was lifestyle. That is going to have that has a huge impact. So we know that already. Okay. If you go to certain good international websites who do population studies, and they give you the data based on what they have found in original population, they have clearly documented everything that you have mentioned, right from extremely hot drink to sleepless nights to people who work continuous late night shifts. All of this has been shown to increase the risk of developing cancer. And on top of that, so maybe you have that kind of profession where you need to do this. But on top of that, having bad health habits, having bad habits like smoking, and unfortunately, people who are awake or who have to be awake in the night, they are bound to smoke more, or having drinks more frequently. So these things have a huge impact. On top of that, processed food, so just let's not even talk about it. Yeah. So, what my worry is when I see kids, even my kids, somehow kids steer towards, they have a liking towards processed food, and the processed food are designed that way.
For that, yeah.
They are designed to attract children. They are designed to attract young people. And then once you are addicted to it, I call it addiction. Once you become, habituated and addicted, you don't like your traditional food.
True.
So we tried at our home, we try to make it a point that my kids, whatever you want to have at the birthday party, it's fine. But you need to have a full proper meal, vegetarian meal at home. So it's a big thing, Luke, and I think each question that you ask is a PhD in its own at the moment. So circadian rhythm, when that gets disturbed, how it develops, how it increases the risk of carcinogenesis. Then you've got, let's say, the high stress, chronic stress, how that impacts and what is the reason behind it. We believe it is the suppression of immune system. Okay, but but um, but I think we need to actually think of what is already available while we're collecting the evidence. So if you have a population study that has already shown that people who are chronically stressed have high risk of cancer, yeah, we will know much more detail of when in future why it is happening, and we will be able to mitigate that. But what it means for you, the message is try to avoid this, right? Try to get good sleep. Do not have chronic stress. So these are things that can work for patients to prevent. And see, I just mentioned about the immune system and high cortisol. So when we are growing up, our bodies are increasing in size because the cells are dividing. Every time the cell divides, there is a risk of developing an error in the genetic code. Some of these errors can lead to mutations that give rise to cancer. But your and my body, it has such an efficient mechanism that it can identify that there is a bad cell there. It goes and kills it. Hmm? Now, what happens in cancer, that these cells become so intelligent that they know how to hide from the immune system. So a suppressed immune system with this kind of bad cells is bad news. Okay, so immunity has a big impact on trying to prevent cancer.
Thank you, doctor, for emphasizing on that, because we also believe at the end of the day, I mean, I was going to talk to you later about science and miracles as well, but we'll bring it up right now. Sometimes we see unbelievable miracles in our patient. While treatments have stopped, they're on palliative. And some of these patients, fourth stage palliative, now they're living their 10th year, 11th year, 12th year. And I look at my data, they've gone through all the treatments possible. The changes they've made, some of them have gotten out of toxic relationships, left toxic jobs. Some of them have completely changed the way they eat. Some of them have made such massive changes in everything that you've actually spoken about. And that just reassures us that there are so many things that we're not putting together, forget about cancer, whether even diabetes, even small hormonal issues. We're just focused on smaller parts of it. In your career, are there any cases that you would talk about where, and as a scientist and a hardcore oncologist, do you also feel that there is, a higher intelligence within us, outside of us, that can actually work? I'm not saying as a choice against treatment, but you suddenly see, we know, like sometimes I know that's not even nutrition working. It's just the body coming back and fixing things with its intelligence. I'd love for you to share some
So
cases.
yes, I've had these kind of occasions where we have seen dramatic responses where it was not expected. Okay, so now, but it is very rare. Now, I'll mention the cases and then we'll discuss why it may have happened. So at the Royal Malvern, there was a patient who had a home in Jamaica. Okay, so he came there. We found that he had cancer of the food pipe. Okay, so and I was working with the best team at that time in the world. Okay, so we made a recommendation. This is what you need to do. Otherwise, the cancer will progress. It is already a locally advanced disease, and you might die in a few months. And this is the message we gave in a different wording, actually. So he said, I am going to go to Jamaica. I'm going to enjoy my whatever days are left, and I'm going to just let nature take its course. So what I noticed about him, he was a very happy man. And I don't know whether you have got some friends from Jamaica or
they're just naturally joyful and
joyful.
Happy. Yeah.
And they're like, doctor, I have enjoyed my life. I'm just going to go back. Okay. So he went back, forgot about it. A year later, he comes and gets the professor a bottle of Jamaican rum or something. He says, I'm back. Just check me out. So we checked and his disease had gone. Then he said he has not taken any treatment. So there is a thing called auto-remission. That is a well-documented scientific fact. And the auto-remission happens when the body's immune system is suddenly able to wake up and identify that there is something wrong. But can we actually replicate that? At the moment, no, we can't. Can we try to? Yes, we can try to. Now, based on this, this is the body's immune system I was talking to you about. So the immune system is constantly trying to fight. Even when we are giving chemotherapy, it is the immune system that is trying to help and assist us. The other case of a patient, I actually will tell you, it's not as dramatic as this, but where we are with our medicine now is that one of my patients, when I was in Nottingham, was about to retire when she got diagnosed with a breast cancer, and we found it is stage 4. So she went and spoke to people and said, other people said, yeah, you don't have much time to live. So she took an early retirement. Now, like everywhere, when you retire, you get a lump sum money. Okay. So she got that money deposited to her account. She was on pension and she told me, doctor, I'm retiring now. Give me the medicine and I'm going to enjoy my life, because I've got this money. So at that point, we had some new drug that had come up on the shelf, which is called a CDK4/6 inhibitor. Okay. So we gave her that tablet, just 2 tablets, hormone receptor positive, disease that had spread everywhere. We gave her 2 tablets. One is hormone tablets, one is a CDK4/6. And she used to take that tablet for a month, and with that in her bag, she used to go on a cruise ship. So she did that almost for 1.5 years. She's traveled all over the world, enjoyed her life. She was doing brilliantly well. 2.5 years down the line, she said, doctor, I have a big problem. I said, why? What happened? She said, I'm not dying. People told me I'm going to die, and I'm not dying. And I said, what is the problem then? It's a beautiful word. Doctor, I have run out of my money, she says. Because she spent all her money, all retirement fund, because she thought I've got only 2 years or 2.5 years. But those are the kind of things. But thankfully in the UK, the government gives them a good pension. So she's absolutely fine. And that is where we are. And even in India, I've seen just recently, one of the patients from railways, a 31-year-old boy, comes in with a very aggressive lung cancer, affecting both his lungs, skull bone, spread all over the body, all over the bone. When I saw, he was smiling, okay, and I said, okay, we will do some investigation and then he kept smiling. I said, do you have any questions? And he said, doctor, I don't have any questions. He was gasping. You can't breathe properly. Yes. So I had not examined him. By then I examined and I found that his air entry in the lung was very poor. We didn't check and his saturation at 72%. Admitted him straight to ICU. And with that level of disease, I had never seen a patient who actually made it. Okay, so we admitted him. But he was constantly smiling, man, constantly smiling. We had to do a tracheostomy for him because we couldn't breathe properly. And then we gave him a very small dose of chemo because we had, with his agreement that we have nothing to lose. Okay, we gave it 60 days. He stayed in ICU. 30 days he stayed in HDU, constantly on oxygen requirement. Then we found that he has a special genetic makeup in the cancer. So we tried something new. We got a specialized tumor board where we agreed on thinking out of the box. 70, 80 days down the line, we did a scan. His disease has almost become like 20% of what it is. He was walking around being absolutely happy. This is stage 4 disease. So these are things that we are witnessing. And again, see the commonality. I'm thinking out loud. Commonality is this: patients were very positive.
Yeah. Happy.
They were not
They
fatalistic.
started to enjoy their lives like the lady. Yeah.
Exactly. So I think there is something, that may be modifiable, but I don't have the scientific evidence, and then some people get really, they're not happy when I'm not able to endorse one thing because we are scientists, ultimately, you and I. We have to go by what is evidence and just clarify very clearly that this is what our understanding is, and this might change when the evidence comes. But we see miracles all the time, and that is one message I like to give to your audience: that don't despair. No, things that were thought impossible are becoming possible. We are able to harness the molecular makeup of the cancer for our benefit. Okay, and in fact, while I was coming here, I actually saw that the Prime Minister Modi was inaugurating a big medical center, and I just saw clay pieces that what we thought was not possible is being possible in terms of cancer now. So it has to go in the public domain, and I love that message that we are not where we were. For many patients, who are unfortunately majority of the patients you might find it would be around 60, 65. So they have this bad memory that 30 years ago my grandmother had cancer and she was so unwell and the treatment was worse than the disease. Those days are gone. Those days are gone. I don't know what your experience is.
Doctor, thanks for explaining that, because I always believe there's hope, there's faith, and there's science. We can't just say that I'm not going to take treatment and live in hope. I love what you explained, and your stories were just like beautiful stories. We have so many like that as well, which we just share with patients at the same time. They've gone through treatments and everything. My take on what you said is absolutely right. People come with past mindsets. They've seen someone suffering. So they say, no, and then this happened to her, this happened to her. So I think I'll stop my treatment. And we're like, first of all, different person, different story, different times. Everything's changed. And if you actually move into, I've noticed one thing, doctor, patients who carry fear and rejection of their treatments through the treatment don't have the best, I'm not saying outcomes in terms of life and death. Everything is suffering for them. The nausea is more, the constipation, the diarrhea, the weight loss. But patients who have like, okay, I've accepted it. They've gone through this, denial, aggression, and then they finally come to acceptance. I feel we've seen a lot of patients when they're helped to think that, okay, this is what you're going through. Like you sit them down and explain the journey. We also take them through the journey on the other side of the medicine. Like this is how your sleep should be. This is what can happen when you sleep better. I feel when patients are in a state of acceptance, I feel every cell of their body is somehow in the state of acceptance as well. But when there's that rejection in their head, I feel they're in a constant state of resistance. Everything becomes an uphill task. Everything becomes more and more difficult. But thank you for sharing those beautiful stories. Doctor, I have two more questions for you. One more. Your thought on second opinions and third opinions as an oncologist. A lot of people, because I've seen a lot of oncologists who work with us, they tell the patient, please go wherever you want. Some get offended. The point is, sometimes people come to us and they say, we're also going to speak to a nutritionist in the US, and we say, go, because at the end of the day, if the vision is to treat a patient, everyone may have different ways. There may be a nutritionist sitting out of Sloan's who has worked on a, ER triple negative more than us and will have some more experience to share, which is great. What's your take? Because a lot of people come and say, Luke, should I get a second opinion? Should I get a third opinion? Like, how do we handle these kind of questions? And what's your advice to patients when it comes to that particular, question?
So very interesting question you've asked, because I'll tell you what used to happen in the UK. So I had a good prior practice also there. So in my NHS practice and prior practice, I used to write in my letter, I have explained this to the patient, and I have also explained that I would welcome if he wants to have any second opinion from any of my colleagues. If they want me to recommend name, I would recommend name, or they can go and do certain. That was the right of the patient. Okay. See, what that does is what that did was it inculcated trust, the confidence that you're doing the right thing, but at the same time you are open to any suggestion. Because see, medical practice ultimately is called practice. We learn a new thing every day. Okay, if you are out of practice for 2 years, you should not be in the thing. You have to reinvent everything again. There is something new that is happening all the time. And like I emphasized earlier on during our talk, that it is about teamwork. It is about building that team. So I'm very proud to say that in HCG, we have got access to 100 oncologists. Every Tuesday, tomorrow morning, we're going to sit down virtually and we are going to discuss complex cases, and we will be open and be critical of each other, and at that same time we come to consensus. So what my worry is, many patients who come to me for second opinion, and there are lots of them because they search me on Google and they want a good profile. They come from all over the country, and when they come, what I fear, what I'm worried about is if they're coming from Bombay, they would not have told their oncologist. Okay, so I tell them that see, in oncology community and in medical community, we are absolutely open for you to go and have a second opinion, third opinion. And if you want, you give them my number. We can have a chat. We can have a talk, and that's absolutely fine. And some of my patients, they went and they came back saying, okay, doctor, they said this is the best treatment you're having. You don't need to change anything, and that builds a confidence for them. Now the flip side, sometimes it does happen that when you see a second opinion a patient and you think something is wrong, then you have to be very strategic about how to tell them, because you don't want to tell
Make
that
the other person look.
But rarely I come across that situation. But we need to welcome this.
Yes, absolutely, everyone. No, thank you for being so transparent with that. I think that transparency builds trust
Absolutely.
and confidence in the patient as well. Doctor, since you specialize with women's cancer, what I'm seeing, and again, this is a little bit more of a discussion before we come to the last question, hormonal imbalance in our country has become huge amongst women and even amongst men. I mean, the kind of problems we're seeing at a young age, PCOS, PCOD, endometriosis, cysts, fibroids, it's just becoming more and more because of lifestyle and all of these things. These are eventually leading to many hormonally driven cancers like endometrial, ovarian, breast cancers. What is your advice to women out there? Okay, that's my first question. The last question is general advice, which I'll come to, because I really feel in our country, doctors are on the pedestal. They have the power to say something and people will blindly follow it. When we look at young girls today coming with PCOS in their 20s and infertility, which is nothing but your entire imbalance in the body, and your chances are way higher. What would your advice be to young girls and women in the way they live their lives, early screenings, then if they get diagnosed, not to be scared? What's your advice to them?
So, see, I do all types of solid tumors. Okay. Now, when I was in Nottingham, I mainly saw all the women's cancer patients. I also built a women's cancer wing in HCG Colaba here in Cooper. So we're focusing only in that wing, we're focusing on women's problem. Now, what you said about the hormone imbalance, that's very true. Okay, see what we have found, especially two types of cancer. One is breast cancer mainly, possibly endometrial cancer also. See, the age of menarche, when young girls when they achieve puberty, that is coming down, and the age of menopause is actually increasing. So, the time period for which a lady is being exposed to high levels of estrogen or hormones is actually quite big. The second thing is people are having kids late. Okay, it's entirely their choice. Okay, I'm not saying you should have.
But it has an impact biologically, no doubt.
Having less children, not breastfeeding. Okay, but again, choice. Okay, so I'm not just suggesting what is right.
Absolutely, doctor.
Yeah. So this is an observation. At the same time, we are, just like I was saying, we will have problems of the developed world. One of the problem is the fat content in the body. It's not just obesity. It is a fat content in the viscera also. Because of the food habits is going to go up. Now, the adipose tissue, which is the fat in the body, has the ability to manufacture its own it has an enzyme called aromatase inhibitor, which increases the amount of estrogen available in the body. So that aromatase inhibitor that is present in adipose tissue, that is inhibited by the tablet called letrozole that I was talking about. So these things, the obesity pandemic, the increased visceral fat, the length of exposure, the situation which are protective, like breastfeeding children, having children, because of these changing, there is a risk. Okay, now that is one thing. The other thing is, hormone replacement also. You have to be very cautious about that. You can have it, but you need surveillance. What I would suggest to young women and girls is understand the risk that you might have in future. See, just by being a woman, you are at risk of developing breast cancer. Men also develop breast cancer, but it is on less than 1%. Okay, and endometrial cancer risks are high after a certain age. So having that understanding of what to expect, how your body is going to change, what is your hormone level going to be, and then modifying that and having the regular surveillance is the key. From the prevention point of view, there are some vaccines for HPV, which is not for hormonally driven cancer, but it must be given to all girls before puberty. Must. If we do that, so if we have 10,000 cases of cervical cancer in India today, if we do that, maybe in 10 years, we will have less than 1,000 cases. So we can actually prevent a lot of disease. Now, with regards to other benign conditions, I'm not medically trained to comment on that because this area is actually completely different. But having the right milieu, having the right amount of hormones in your body at the right time is extremely important. Because remember, you can't just say, I don't want the estrogen or I don't want a testosterone. Yeah. And these are happy hormones, right? In fact, I'm sure you will be able to tell me more about this. There are studies that where people are trying to increase the levels of testosterone, estrogen, so that they can live longer and
for this whole longevity.
For whole longevity. So we have to be able to strike the right balance. So my thought is, in future, we will have this understanding of how to switch on and off certain genes, which may be predisposed to develop cancer. But that's talk for another day.
Doctor, I wanted to ask you something that actually troubles me quite a bit. Not mostly on a daily basis, but it happens quite frequently. We have you as a renowned oncologist on our show. We've had many other oncologists, cardiologists from India and across the world. And everyone like you, we speak about the importance of nutrition, speak about being careful of ultra-processed and processed. And then sometimes we have patients who come not just to us, we see this around the world, and they'll say, my doctor said, eat everything. Have ice cream, enjoy sugar, do all of these things. Now I understand. We also have patients who are palliative, 2 weeks, 3 weeks. We're never going to put them on a diet. They're going through multi-organ failure. They are going to die. If a miracle saves them, great. We don't expect them to be on a diet. We don't want them to eat what you want. But patients who are in a stage 2, stage 3, already going through gut issues, already going through nausea because of the treatment, the whole world is trying to tell people, eat healthier. But there are some people in the medical industry who tell the patient to eat what they want. Now, whatever reasons they have, these are not palliative reasons. The patient now comes and says, and they're fighting with the family because everyone's trying to get the person to eat right. I'll eat what I want. They're ordering junk food. They're ordering all of that stuff. I used to understand when I first moved to India that, of course, you got to maintain a certain weight for your chemo. But then there's the right way to do it and there's the wrong way to do it. There are foods that will create inflammation, and then there are foods which will not create inflammation but help you put on weight. Doctor, how does this change in the world of medicine? Like, there's a lot to be changed in the world of nutrition. Like, I'm against nutritionists who supply laundry lists of supplements to patients just because they read milk thistle is great for liver, and you're giving it without keeping the doctor in the loop. So there are issues in every pocket of medicine and every field of expertise. But how do we eventually, I've had many thoughts of writing to ICMR, writing to the IMA, because the IMA also invites us to talk about nutrition. So if you're inviting us, it is important. But then why is there a discrepancy in what patients sometimes hear from very few people, but the rest of the doctors are like yourself, you're encouraging people, take your meds, change your lifestyle, do it better. Why does this happen, doctor?
So we need to be very clear of what our goal for the patient is. Yeah, having the target in mind.
Intention.
See, my target is to give the best treatment to the patient, but at the same time make him happy and let him so that he's able to cope with the treatment. So sometimes I come across a foodie, and then I did come across a lady who used to travel all the way from, I think, Borivali down south just to see me. because we develop that rapport with the patient. She just could not live with pani puri. She could just not live with, she comes from a traditional Gujarati family or Jain family. She loves food, loves to eat. But her family was stopping. Okay. So I said to her, so what do you like about it? Then I have this sense of, because I like to cook as well and I like to eat. So then we figure out that actually she had this very innate connection of love associated with food. Okay, and this is what mothers, and she used to feed her child as well. I told her, and this maybe I'm letting a trade secret out. You can eat anything that you want as long as. Now that as long as is very important because what you're giving the message is that, see, we don't want you to stop enjoying life.
Correct. Yeah.
We don't want you to stop living. You want to have, let's say, pani puri, but you can't have it outside.
Yes. Have it home. Make it at home.
Yes.
Yeah.
Now we all know how frequently is it possible for her to make it at home. It's not very possible because I don't want her to have that kind of infection and that sudden rush of things from outside, and it will derail my plan completely. And I'll tell you, during my PhD, I actually showed it in data. We're thinking of, extremely expensive chemotherapy and those kind of treatment, and a patient develops a UTI. There's a delay of 2-3 weeks, and the outcome is very bad. So these little things do matter. So having that understanding of why you're doing things, what you're doing, and being very, and I dare say this, you have to be very strategic the way you communicate with the patient. You can't just say you eat anything and not qualify it. Okay, because sometimes they find patients who are foodies, they find it very restrictive. But on the other hand, there are patients who want to know exactly what to eat. So see, my message to simplify things has always been freshly cooked, homemade, healthy food. Now that covers everything.
We don't need exotic, fancy, nothing. Just simple. Yeah.
And I tell you, see, now you talk about if even a person is vegetarian, almost 90% of leafy vegetables are not available in hotels. You have to cook it at home. 90% of the beans are not available in hotels. Okay, we sitting in Taj. I think there are some of the beans that you cook at home may not be available even at Taj because there is no demand for it, right? So these things cover that, and I see food plays an extremely important role, and when it comes to actually maintaining health and being able to cope. So this is for the curative patients. For patients where we know we don't like to use the word palliative. Personally, and I think this is coming from my association with the chairman. But that palliative thing was there, but palliative is a very depressing. It's like giving up. And for us, we don't want to give up on patients. Never give up on patients. And if we don't give up on patient don't give up on us. They have that, that is the kind of relationship that you need to build with patients. Because at one point in not too far future, we will be able to control the cancer and allow the patient to live their normal lifestyle. In many instances, we are already there. We are getting there and we will get there. Okay? But in case we have a situation where we know that a patient is 85-year-old, okay, they have lived beyond their normal lifespan. There are other comorbidities, and they might you may not be able to give them the toxic treatment. You can give them nutritionally sustainable, the best kind of advice. But at the same time, let's say he's got last 3 months to live. Do you really want to deprive them of some pleasures in life?
Absolutely not. Absolutely.
So it's a very circumspect thing. And then most of us will want to do what is good for the patient. Yeah. So this has to be real. And then again, we are not taught well enough about nutritional aspects. I'm hoping that with what you mentioned about your integrated course on nutrition, and that you're working with some universities yourself.
Yeah, we're happy to train.
Yeah,
that the whole idea is we're happy to train people.
So that is something, a good initiative, and will help patients to cope and deal with this better. But that message of eating everything, having junk food and pizza and meal, just not advisable. Just not.
Thank you, doctor, for that. Doctor, before we end, this has been so informative. And like you said, each topic could be a PhD discussion on it. What message would you leave for all of our audience? Coming with your life experience as an oncologist, as a father, as a human being, based on what's happening in our world today, what would you leave our audience with? What message would you leave to them?
So I'd like to say that, see, cancer has been one of the biggest enemies for all of us for a very long time. But currently, we are at the cusp of revolution. We might already be living in a revolution because we have developed new strategies and new drugs, and we have newfound knowledge, which is not focusing only on the cancer, but is focusing at the comprehensive cancer care, such as nutrition, health, coping mechanism, but also looking at a disease at the molecular level. This is allowing us to fight cancer like never before. Like I just mentioned to you, very soon in future, even with patients with advanced disease, we want them to live well, live their normal lifespan, and enjoy their life. So if you get cancer, please do not despair. Do not despair. There is a lot we can do, and we see that all the time in our patients. And our patient serves as inspiration. Life is worth living. That's what the patients tell me. Yeah. So please do not despair, even if you get cancer. But let us think about how to prevent cancer also. Okay. What are the strategies you can adopt? What lifestyle modifications you can make? And see, there is a lot of information that is available there. One is think about it. Go and see the right person at the right time. Get some preventive strategies. Next thing is do not ignore screening. Okay. Screening is available all over the country in good centers at a very fraction of a cost what it is done in the West. Please use that. Okay. So with all these things, I think we will be able to fight cancer in a much better way, much better than before. And we will one day hopefully be able to beat cancer as well.
Dr. Sachin, thank you. It's been such a pleasure. Thank you so much for your time. Thank you.
Thank you.
Stay tuned for more. We're going to continue our journey, learning, sharing, and evolving.